Today's online lecture will be covering selecting, administering, scoring, and communicating assessment results. And so as we learned about in the first class, here are just a review of some assessment search resources. So the Mental Measurements Yearbook is something that's available where we can actually obtain physical measures and assessments, PsycInfo, PsycTest, and then also the USF library database that Amy went over with us in the first class. There's many important considerations that we need to take into account when choosing assessment measures, and so I'll just go over a few of them here. We want to have a good understanding of the development of the instrument and also the purpose of the instrument. And so, if detailed information about the development of an instrument is not provided, we want to be concerned. We really want to know more about what psychometric properties the measure has before we use them. And so, for many instruments, the development of items plays a central role in instrument construction. And we also, again, want to have an idea of what is the purpose of this instrument. So, is this a screening tool that's going to need more information from us to follow up on, or is it a diagnostic measure? So, just getting curious about some of these things. We want to be aware of reliability, which, as we went over in class on Tuesday, is how well the measure does over time. And then validity, is the measure measuring what it is supposed to? Fairness, norm, and cultural considerations. So we really want to take into account who was the sample and should the measure not be used with certain populations or with caution. So we really want to be able to detect some of these biases and also with strategies that are used to detect these biases. As far as interpretation and scoring materials, we also want to be familiar with how you score and interpret the data. Is it done by a computer? Is it done by hand? And then as well, user qualifications. So who is actually able to administer it? Practical issues are also something to take into consideration as far as space and time. Does it need to be done in a certain amount of time? For example, something like the GRE is something that's tested and timed. So as far as selecting assessment instruments, here are some strategies that we can keep in mind. We need to first determine what information is needed, analyze strategies for obtaining information, search assessment resources, so that might be something like Mental Measurements Yearbook or PsycInfo or any of those other scholarly databases, evaluate the assessment strategies like we just went over, and then we want to go ahead and select an instrument or strategy. So when we look at what information is needed from the assessment, we want to identify what type of information are you seeking for the client. General information clinicians need about clients. We should also be considering information that is already available without the use of the measure. So if you turn to page 125 in your text, you can see here an example of a form that you could actually utilize to evaluate assessment instruments. So some examples of questions on this form to ask yourself. And again, this is so that you can evaluate if this is an appropriate assessment measure. Is the purpose of the instrument clearly stated in the manual? Does the purpose of the instrument meet my clinical needs? Do I have the professional skill and background necessary to competently administer it? And I'll just skip around here a little bit. Did they perform an adequate item analysis of the items? Has reliability been explored sufficiently? Does the instrument appear to have acceptable reliability for my uses? So again, we want to think of that 0.7 or higher as far as clinical practice goes. And you can also just take some time and look over these other questions on page 125 of the text. So there's formal or informal techniques of assessment. As we've mentioned before, interviewing would be a more informal, and formal might be a written form or measure. And again, we want to consider which assessment method would be best suited to the client. And so with the younger children, we might not be able to do, for instance, a more formal assessment measure, because what if the child is not at an age where they can read, or if they're not able to write or spell? So we may have to adapt this depending on the developmental age of our client. And we also want to consider professional limitations and, again, which instruments we can ethically administer and interpret based on our own qualifications. So as far as administering the assessment instrument goes, we want to read the administration materials ahead of time and know the details for administration. We basically want to be familiar with the testing materials and equipment that's needed and know the boundaries of what is acceptable. As far as scoring goes, there's a number of different ways to score measures. I'll show you an example of a scoring of a certain measure. We'll talk a little bit about the DAS 21 later in this lecture, and I'll give you I'll actually show you the scoring program. So we can hand score, computer score, or can be scored on the internet. Some assessments can be actually self-scored by the client. And before using computer scoring, we also want to investigate the integrity of the scoring service and steps used to develop the program. And so at the end of the day, you are responsible for scoring the measure properly, whether that be by hand or on the computer. And so it's important that we're aware of the systems that we're utilizing for scoring. And some assessments may also require clinicians' judgment as part of the scoring. So that's something to keep in mind when we're thinking about an evaluator bias, or when we are thinking about having to actually bring judgment in as part of the scoring. Performance assessments and authentic assessments. These are more objective scoring. They involve performance of real, authentic applications rather than proxies. And objectivity in scoring can be a bit more difficult to achieve. And in general, so that's why we want to actually enhance scoring by using a rubric, an evaluation checklist, or a common evaluation instrument. Communicating results. This is a really important topic, and it's something that you're going to have to be doing a lot as a marriage and family therapist. So it's often one of the most important parts of the assessment process, and it also often happens and can happen early on in the relationship with the client. And so how we communicate results may actually inform what the relationship looks like and rapport with the client moving forward. And so it definitely requires some specialized knowledge and competencies. And again, communicating results is interwoven into treatment. We're not just communicating results at the beginning of treatment and then not until the end. And we always want to connect directly the result communication to the focus of treatment. So let's think back to why is it that we're using assessment measures. So one of the number one reasons that we're using assessment measures in general is to find out more about what is going on with the client so that we can support them with getting connected to the services that they need. And so sometimes diagnoses and just general results from assessments can help us to get them connected to the services that they need. So we can actually directly connect the focus of treatment when we're communicating results. So there's actually little research related to communication of results, but there has been just, some studies that have shown that clients prefer individual interpretation to group interpretation. That sort of makes sense. Tentative interpretations are more helpful than absolute, and I think we should always be keeping this in mind. Really what this means is that we're making inferences and hypotheses. We're never saying this is the end-all be-all absolute absolute of what is going on for a human. And so we really want to use caution and utilize language that is more around hypotheses and inferences than absolute truths. And also, a good year in 1990 showed that clients who received test interpretation experience greater gains than those who do not. And so, what this was looking at is people that had taken the same test. Those that did not get the interpretation given to them had greater gains in treatment than the ones who had the assessment done and were not actually given the interpretation. So again, we want to know the information in the manual. People are going to be looking to us as experts, and we want to just generally use effective general counseling skills. And so keeping in mind that rapport and camaraderie is number one in making the client feel comfortable and safe. So we want to develop multiple methods of explaining results. I often actually will use a visual. So I might actually draw a diagram or a chart and go through it with a client, especially this is useful with younger kids, using visual aids to explain technical terms. And so actually, as I've mentioned, I specialize in OCD. So the OCD cycle is something that can actually be broken down into a very clear visual aid that shows triggers in the environment, obsessions that then lead to feelings of distress, that then actually lead to compulsions, which leads to temporary relief, and then that actually feeds into the cycle. So when I'm explaining results, if someone has OCD, I'll actually bring out this visual and go through it with them. And folks are often reporting that this is really helpful to have a visual explanation and really just put what can be complicated clinical jargon into more accessible terminology. And so, again, we want to use descriptive terms rather than numerical scores. People don't really know what the numerical scores mean, and it can be confusing. And so I might just say, since we're talking about OCD, if someone scores a 34 on the Y box, which is in the severe range, rather than saying a 34, I might just say that it was falling in the severe range. And again, we want to provide a range of scores and rationale for the assessment. So again, this is all about connecting to the proper services that are going to help them and using probabilities rather than certainties and tentative interpretations rather than absolutes. So we also want to discuss the results in context of other information. We're really, you may have someone who's coming in seeking treatment specifically for depression, but then through assessment, what if you hear about a past history of trauma, for instance? And so we want to be keeping in mind when doing assessment, and let's say we were discussing results of a depression measure with someone who is coming in for depression treatment, we would also want to keep in mind the trauma history and really keep in mind treating clients as a full human versus whatever disorder they're coming in to be treated for. Involve the clients in the interpretation. I always check in with, after I've communicated assessment results, I'm asking them if it sounds accurate and what their thoughts are. When I'm telling you that your depression seems in the moderate range for the last 2 weeks, how does that sound to you? Does that sound accurate? Is that a clear representation of what you're experiencing? And then we also want to monitor client reactions during interpretation. Sometimes it may be difficult for a client to hear some interpretation that's being delivered, and so we want to be mindful of this and supportive. We may need to pause, check in with how the client is doing. And again, we also want to provide a space to discuss limitations of assessment in non-technical terms. And always, always, always encouraging the client to ask questions. We really want to make sure that clients do not leave confused or ill-informed about the results. And then we also want to summarize and again just check in about how their understanding is about the information that you've delivered. Communicating results to parents. So we'll have a whole other lecture specifically on working with families and kids, but something that I did want to bring up is just a few points here. So we want to be prepared to answer questions and explain results. Parents are often, when it comes to parents bringing their kids to treatment, they often have a lot of questions, and they often do want to know that the person that's going to be in charge of their child's mental health care is knowledgeable and able to answer their questions. And results may also need to be discussed more than once. Some examples of common questions can be found on page 133 in your text. I'll just read a couple that you could get from parents. So, why are the scores so low? What is an achievement test? Who was in the comparison group? What do these results mean for the future? I think that's a very common one. Who will see these results? So you want to be able to talk about confidentiality and how the results will be kept. Could my child have done better? Where did the questions on my test come from? And then what can I do to help my child? So this is obviously a really big question that is a very common question from parents. And so we actually also, if we are treating kids, we could look at this as we're also treating the family and going to need to be knowledgeable about recommendations for how parents can help their children. And so we want to understand the testing used and symptoms of the child's disorder, as well as associated diagnostic criteria. And we know that certain disorders that show up in childhood may manifest differently or look differently than the same disorder in an adult. For instance, with depression, it often doesn't show up as sadness in kids. Oftentimes it can look like irritability or hostility. And so we need to just be mindful of that and know these discrepancies. We want to help parents adjust to the diagnosis. I really just think normalize here. These diagnoses are made and we have them so that we can understand what is going on in order to get them linked to hopefully evidence-based treatment. And so that's really why at the end of the day we have diagnoses. And I think normalizing it can just help parents feel a little bit more adjusted to it, because at times, parents may get a little bit worried themselves when they hear that their kid may have a diagnosis. Again, we want to be prepared to use a variety of techniques, focus on active and coping approach, and always acknowledge the parent's emotions. So just as much as we are building rapport with a child, if we're working with a child, we are also building rapport with the parents. And we really want to acknowledge and validate their experience, and also acknowledge and validate their willingness to be a part of the process. And as well, again, just as we would for an adult or anyone else, we want to allow time for questions. So psychological reports, just a bit about this. The purpose is really to disseminate assessment information to parents or other professionals. This is often commonly done in the school setting, or you may have heard of a neuropsychological report for attention deficit hyperactive disorder. So that's not something that MFTs are typically doing, but you may need to help deliver assessment results for ADHD or interpret them rather to parents or teachers. And we want to expect a comprehensive overview of client and interpretation of results in contextual manner again, and these should be carefully crafted with attention to detail. And if you are creating them, or even if you're reviewing them, be alert for typographical errors, use of vague jargon, so words that don't make sense to other people, careless mistakes, and lack of detail. Some common areas that are often exist within psychological reports are identifying information. And so at the beginning of a psychological report, there's usually some demographic information that includes the client's name, the date of the examination, date of birth, chronological age, date of report, grade or occupation, and then also the examiner name. The section of reason for referral, so why was there a referral made for testing? And we could also think of that in practice as, presenting reason for treatment. The background information, and so this is really providing sufficient detail about the client's past so that the reader can understand current issues and concerns. There's then a section for behavioral observations. So these are actually observations that are often done of the child in their natural environment. So there could be observations done in the home setting, in an after-school setting, or even in the school setting. And so I used to work for a community mental health agency called Seneca Family of Agencies here in San Francisco. And part of my job as a therapeutic behavioral services clinician was to go into the classroom and conduct behavioral observations. And so actually, typically this is done anonymously, so the client or student wouldn't actually know you before you do the observation, because otherwise it can get in the way of the child acting normal as they would in their natural environment. And so typically you might go in, sit in the back of the classroom, and then you're writing down observations and noticing if there's any certain behaviors that are happening in the environment. And again, this behavioral observation can also include mental status. And so the mental status exam, for example, if you were seeing a teenager in your session and doing an assessment, you could say something like, the client appeared tense and was chewing on her fingernails. She reported she was anxious about the testing. This is an example from the book on page 136. Assessment results and interpretation. So this is really where the bulk of the scoring that comes from the assessment would be written, and then as well diagnostic impressions and summary. And so again, even if you're not doing a full psychological report, there's many times where you might be given a psychological report if you're seeing a client who has previously had psychological testing. You actually want to get a copy of that report for your own files. And so you'll be reading and interpreting it yourself. And so this is why it's just important to understand what's in there. And then there's always the signature of whoever was doing the report. So I'm just going to go over a few common and easy access screening tools. So the Beck Depression Inventory 2, and we have gone over this a bit, but I'll just show you it here. And following this lecture, you are going to listen to an audio recording case study and utilize the Beck Depression Inventory in order to score this client and answer some questions about this client. So I'm just going to bring up the BDI so we can look at it. This is the most commonly used depression inventory. So we can just see here, looking at sadness, pessimism, past failure, loss of pleasure, crying, suicidal thoughts or wishes, self-criticism, punishment feelings. And then here we have the scoring for Beck depression. So total score of 1 to 10, normal ups and downs, 11 to 16, maybe a mild mood disturbance. So these are classified as low levels of depression. Moderate is 17 to 30. And so you can see 17 to 20, borderline clinical, 21 to 30, moderate. And then we have significant, which is 31 and over, severe being 31 to 40, and extreme being over 40. So these are just some levels of depression. And so for you as the clinician, you might be interested in this area here with the numbers. And then when delivering the results, we would want to talk about it using this other language. So another common measure is the DAS-21. So this is the Depression, Anxiety, and Stress Scale 21. This is a really easy measure that can be self-administered, and so you can print this out or even email it to your client and have them fill it out before the session. And here we can see it's on a Likert scale, so 0 to 3. 0 did not apply to me at all, 1 applied to some degree, 2 applied a considerable degree, or 3 applied very much most of the time. I like this measure because it does also screen for some suicidal ideation. So you can see number 22, I thought about death or suicide. 23, I want to kill myself. And so this does a nice job of measuring stress, anxiety, and depression. And I will show you a easy scoring program. So this is actually a scoring program for the DAS-21. And what you would do is you would have the client fill it out. So you can see here side by side. So I found it hard to wind down. Number 1, we can see over here on 9/8/17, this client put a 2. So they were saying applied a considerable degree, and then you just kind of fill it in. So if you were, let's just say hypothetically, we were filling it in for today. So we could go ahead and I'm just going to put in some random numbers and we'll see what happens in the scoring program. So let's do 1, 2, 3, 3, 3, 2, 2, 1, 1, 0, 0, 0, 0, 0, 1, 2, 3. So you can see here, based on what I'm putting in, what happens. And the scoring program is nice because it actually shows you. So what I just put in actually indicates 22 for depression is very severe or severe. 18 for anxiety is also very severe. 14 for stress is normal. And then we didn't have anything in the suicide questions. So you basically just go through and plop these over here. And then what's nice about the scoring, as you can see, is we can see on a plot graph how the client is doing. And I might actually share this visual with the client. So you can see here before I entered this in, and this was a real case study, this client was actually progressing quite nicely on this measure beginning in September and going through January. So you can see how the levels are decreasing. So that's the DAS-21. The next is the GAD-7. So this is again a really easy, quick screener tool for generalized anxiety disorder. And so again, it's 0 to 3, and the client is asked about different questions that are common to people with generalized anxiety disorder. And then scoring for this, it's 5, 10, and 15 are the cutoffs for mild, moderate, and severe. And you can find this one online easily, and it's a free measure. Mood disorders questionnaire. This is a really helpful screener for bipolar. And so this actually shows a little bit of the psychometric properties on here. So it is sensitive for bipolar 1, but is not as sensitive for bipolar 2, which is depression and hypomania, and or bipolar not otherwise specified. So this would be better for assessing bipolar 1. And again, it's just a screener. But we can see here sensitivity and specificity, 0.7 and 0.9 for outpatient clinic. So it's not bad. It's a promising measure, I would say, as a screener, but I would not use it by itself. So again, this can be self-administered too, and then you would want to follow up, and you can actually use this for some clinical conversation too. So we can see here we're assessing for DSM-5 criteria of manic episodes. One thing this doesn't ask about, it asks about if it happened for many days, but it doesn't ask about how many days. And so for hypomania, we need for these symptoms to be lasting for at least 4 days, and for mania, it needs to be for at least a week. And again, also here, it says, have any of question 2, you can see, have they ever happened during the same period of time, but it doesn't ask how many. So we would need to follow up and ask the client. This one, the Panic Disorder Severity Scale, is another self-report form. This is a really useful tool for panic disorder. I'm often using this with clients. I really like how it defines a panic attack, which is what we need to have. So we need to have at least 4 of those symptoms, and they must peak within 10 minutes. And so it's a fairly short measure. And then you can also find the scoring right here. So items are rated on a scale of 0 to 4. And so 4 would be very severe and 0 is nothing. And so what you do is you actually take the raw score and then you can convert it to the composite score to see where the person falls 0 to 4. And so you can see here, it's copyrighted, but permissions granted to reproduce this scale. So this is open to the public. Social anxiety disorder. So the APA has actually offered a number of what they're calling emerging measures for further research and clinical evaluation. And so these are utilized in the initial patient interview and then also to monitor treatment progress. And so as it says here, they're useful tools to enhance clinical decision making, but not as a sole basis for making a diagnosis. And so we would want to go back into DSM and we would, go through there after using this measure and make sure that the client actually does meet criteria for social anxiety disorder. We wouldn't just use this measure, but it is a helpful tool. This is the adult version. There's also a child version of this. So it's going on the past 7 days, and then we can put the total or raw score. And then this is actually the scoring. So you basically just take the total raw score and you divide it by the number of items that were answered. So it's 10, and then it's scored on a 5-point scale, and it's 0, 1, 0 never, 1 occasionally, 2 half of the time, 3 most of the time, and 4 all of the time. So we can think about this as if once we're doing the average score, 0 would be none, mild 1, moderate 2, severe 3, or extreme 4. And we would also want to complete this one at regular intervals. So I typically, in outpatient weekly treatment, I would have someone fill out these monthly measures once a month. In intensive outpatient, we actually have them fill out these types of measures once a week. And then here's the Y-BOX, which is the Yale-Brown Obsessive Compulsive scale. So this is actually the checklist for OCD. So it actually goes through all of the categories, and I would go through this. This is clinician administered, so I would go through this with the client. And you're asking first about obsessions. So we actually would define those obsessions as unwanted, intrusive thoughts that are repetitive in nature, that cause distress. And we'd want to ask if they're currently having them, or if they had them in the past, or if they've never, and then you can just mark off. So we have all these categories: aggressive obsessions, contamination, which is a common one, sexual obsessions, hoarding, saving, religious obsessions, which we call scrupulosity, obsessions with need for symmetry or exactness, miscellaneous. And then we have compulsions, which we tend to think of as the responses to obsessions. So these are repetitive actions that can be mental or physical in nature, that are utilized to reduce distress temporarily. And so we have washing, cleaning compulsions, checking compulsions, repeating, counting, ordering, hoarding, and mental compulsions, and then miscellaneous. So this checklist is really helpful because a lot of times folks with OCD will not disclose the content of their OCD necessarily, or you might miss something. And so you can actually just go through this, and that way you know that you've accounted for everything. Because if you're treating OCD and you only know about some of the symptoms, then the client may be engaging in other compulsions that you're not aware of, and it would actually possibly sabotage or negate the effectiveness of the treatment. And so then this is actually the severity measure. So it asks about, again, obsessions and compulsions. So time, interference, distress, resistance. Then we have degree of control. And then we have the same questions for compulsions. And so scoring for this 0 to 7 is subclinical. So we would not give the diagnosis. Someone has to be actually engaging in obsessions and or compulsions for at least an hour a day to meet criteria based on DSM-5. 8 to 15 mild, 16 to 23 moderate, 24 to 31 severe, and 32 to 40 extreme. And this measure has shown good reliability and validity, but it does need to be administered on a weekly basis in order to uphold that efficacy. And it's the most widely known and utilized measure. There is a few problems with it. One of the questions is about degree of control over obsessive thinking. So how much effort have you made to stop or control thinking? And we actually know that that doesn't work and it's not helpful for obsessive thinking. And so we've moved more towards, in the field, learning to accept and allow distressful thoughts versus try to get rid of them, because we know that that doesn't work. But they have not developed an update to this Y-BOX at this time, although there has been some talk to updating it. And so again, these are just some common and easy access assessment and screening tools, and feel free to bring any questions about any of these into class on Tuesday.